All right, everyone. I think that we will go ahead and get started. I want to welcome everyone to the next webinar of the Histiocyte Society. This is sponsored by the HLH Steering Committee. And today we're very, very honored to talk about the yin and yang of HLH and T-cell engaging therapies. So as many of you know, there's been great growth in the use of T-cell engagers like BiTEs and CAR T-cells. And use of these can both induce hyperinflammation and, as shown more recently, can be used to treat hyperinflammation. So we thought that would make a really interesting topic for today's webinar, and hence the yin and yang. So before we start, I would like to go through a few background slides. Of course, we're all very familiar with the Histiocyte Society as a group of 200 physicians and scientists interested in advancing knowledge and improving outcomes for patients with HLH. HLH is my favorite disease, histiocytosis. We can move ahead. So all of the participants will be muted. If you have comments that you would like to post either to one another or to the staff, please post those into the chat function, which is of course down on the bottom of your screen. Once you click on it, the chat section will open up and you can enter your comments. You can move ahead, Kathy. If you have questions for the speakers that you would like to pose, please put those in the Q&A box. Okay, so these will go directly to the speakers and panelists, and then Rebecca or I will moderate those at the end of each presentation. You can go ahead, Kathy. Of course, we thank our sponsors, Histiocytosis Association, Artemis Association, and Histio UK. And okay, so one more thing before we go ahead. I know there will be a survey at the end of this. I'll very much forget to remind you to fill out the survey at the end of the presentation. So please keep an eye out as you log out for the survey and complete that. So with that, I'm very, very pleased to introduce our first speaker, Dr. Zhao Wang, who has so kindly agreed to join us at midnight from Beijing, who will be treating on the treatment of CA-EBV, EBV-HLH with PD-1 blockade. Dr. Wang is director of the Department of Hematology at Beijing Friendship Hospital, Capital Medical University, and he's chairman of the Professional Committee of Histiocytic Diseases, Society of Hematologists. He and his team are leading the development of Chinese guidelines for the diagnosis and treatment of HLH and consensus on lymphoma-associated HLH. As we all know, he has developed and tested multiple regimens for the treatment of various forms of HLH, has published on many of these, and has won several recent awards for these efforts. So today, Zhao, we really look forward to hearing your presentation. Thank you so much. And now, Kathy, you can stop sharing if you don't mind, and we'll have Zhao share his presentation.
First, thanks the Professor Li Kong's invitations and the introduction. And I'm very glad here to share my work with. So today, I will talk about the treatment of CA-EBV and the EBV-HLH with PD-1 blockade. I'm Zhao, coming from Beijing Friendship Hospital. So at first, I want to talk about the PD-1 antibody and the lenalidomide treat the CA-EBV, chronic active EBV viral disease. And for this research, we have registration of clinical trials on September 2019. And this is open label, single center, prospective clinical trials. And we enrolled both children and adults patients for these clinical studies. This is the dosage for these regimens, including PD-1 and lenalidomide. Altogether, 34 patients were enrolled, but only 24 patients have finished at least 3 cycles of treatment. So we at first only analyzed these 24 patients. For these 24 patients, the median age is 16 years old, and female is 9, male is 15. And here we can see the dark blue, that means the patient have finished at least 6 cycles. For the light blue, that means the patient only finished finish 3 cycles, but didn't reach 6 cycles. And here we can see if the patient have finished 6 cycles treatment, about 45% can get response, and 33 patients can get CR. But if the patient only finish 3 cycles to 6 cycles, only 37 patients can get a response, and only 25 patients can get a CR. And here we can show is 24 patients EBV virus copies changed after the treatment. And here we can see the EBV DNA in PBMC show a downstream trend with the course of the treatment. The copies of the EBV DNA have decreased with the cycle of treatment. And this slide will show if the patient after the treatment get a CR or PR, the CD8 positive T cells have significant increase compared with the NCR patients. And we also found for the effector memory CD8 T cells have greatly increased after the treatment in the response group compared with the no response group. And we also found after the treatment, if the patient get a CR or PR, the interferon gamma and the CD27, CD13, CD30, CXCL9, and the CXCL10 have increased significantly increased in the response group compared with no response group at the after the treatment at the 4 weeks and the 8 weeks. And also we can find for the NR group, the mutation load of CNV is more common compared with response group. That means if the CAEBV patients have more mutations load of CNV before the treatment, the outcome is more poor. But after the treatments, the response group show an obviously increase in the load of CNV level after treatment. For these 24 patients, about 2 patients was died. The median follow-up time is 17 months. And the possible drug-related adverse events, we can see about 2 patients has been induced HLH after the treatment of PD-1 antibodies. And here we can show the altogether 34 patients have enrolled in the clinical trials. And 4 patients stopped the clinical trials because of the CAE. And 6 patients have dropped out as some reasons. Altogether, about 6 patients died until now. This is 1 patient has been induced HLH after the treatment PD-1 blockade. This patient is 22 years old, is male, and recurrent fever for 11 months, and has the EBV DNA copy is very high, and sphenomegaly, hypotomegaly, and in the liver biopsy, intestinal biopsy, and the lymph node biopsy, the EBR is positive. And also we found in these patients, CD4 T cell, CD8 T cells, and the CD19 B cells, and the CD56 NK cells, the EBV is positive. The patient has been diagnosed CAEBV and had been enrolled to our clinical trials. we treated the patient with PD-1 and lenalidomide. After the injection of PD-1, the patient get the persistent fever. 1 week later, the patient get very severe pancytopenia, and the ferritin is very high, and hypofibrosis, and the soluble CT25 is also increased very quickly. ALT and AST is very high, and the bilirubin is also increased very quickly. But the EBV virus DNA is still very high, didn't increase. So we diagnose this patient has been induced HLH and PD-1, and we treated the patient with ruxolitinib combined with DP regimens. And very luckily, the patient recovered very quickly. But unfortunately, the patient was died 4 months later because of severe gastrointestinal hemorrhage. And here we can see, after we give the treatment of PD-1, the white cells platelets decrease very quickly, and the ALT, bilirubin increase, and including ferritin increase very high. After the treatment with ruxolitinib and the DP, they recovered very quickly. So we want to confirm our results. We registered a new clinical trials, and this is a multi-center, prospective, randomized, and double-blind clinical studies. This clinical trial is still going on. For this clinical trial, we want to know what kind of CEBV can benefit from the PD-1 antibodies treatment. So from our clinical trials, we can see some of the CAEBV patients can benefit from the treatment for PD-1 antibodies. Why the EBV virus can decrease after PD-1 blockade treatment? We think perhaps it's the EBV infection contributes to the CTL dysfunction, which may be related to the overexpression of PD-1 and PD-L1. And then the mechanism of PD-1 blockade is effective in CAEBV, may be related to the recovery of CTL's function and the proliferations. And then this paper have shown for the NKT cells in lymphoma, the EBV-driven latent membrane protein 1, we also call LMP1, can upregulate PD-L1 expression. And we also can see for the nasopharyngeal carcinoma, the EBV also can induce PD-L1 expression. And these papers also think LMP1 induce PD-1 expression through the downstream pathway involving JAK3 and STAT3 and AP1 and NF-κB for this pathway. And this another paper have shown chronic lymphocyte leukemia patients combined with the EBV infections. And the paper think the EBV induced PD-1 and the PD-1 overexpression. And this paper, the conclusion is rescue of CD8 T cell response is because of PD-1 treatment. And this conclusion is similar with us. This another paper have shown they treat the relapsed and refractory EBV HLH patients with PD-1 antibodies, and they get very good results. Of course, only 7 patients. In fact, we have begun the similar clinical trials about 2 or 3 years ago, but our outcomes is not as good as this report. And some patients, they have progressed very quickly. The HLH progressed very quickly after the treatment of PD-1. So we give up the clinical trials. And then this the data come from the WHO. We can see about 168 patients after the treatment of PD-1 have gotten hematological complications, including ITP, HLH, and HLH. About 25 patients have got HLH. So we should be careful. How to play the positive role of PD-1 blockade and avoid aggravating HLH conditions in the treatment of EBV HLH. And we designed a new clinical trials to treat the EBV HLH patients. It's a sequential treatment with PD-1 blockade for EBV HLH. The first, we use the DP regimens to control the cytokine storm. Then follow the PD-1 antibodies. We want to hope to decrease the EBV virus. And we also have registered clinical trials. And we see DP combined with PD-1 antibodies as a treatment for adult refractory and relapsed EBV HLH. This is an open label, single center, prospective clinical trials. And altogether, we have enrolled 16 patients. After the treatment, 4 patients get the CR without transplantations. The EBV virus has gone, even without transplantations. 4 patients have followed allogeneic transplantations. 3 patients get a CR, but 1 patient relapsed. But now the condition is very poor. Another 2 patients is waiting for the transplantation. 6 patients died. For these 6 patients, they didn't get a response from the treatment, from the PD-1 and the DP protocol treatment. So then the condition is very poor, cannot bridge to the transplantations. So they died very quickly. And for all these 16 patients, here we show the possible drugs-related adverse events. But for these 16 patients, we didn't watch HLH rapidly progression. And we all know for the CAEBV and the EBV HLH, the commonly associated with gene defects, such as CD27, CD70. So for these patients, we don't think we can get good results after the treatment of PD-1. So if we treat the patient with PD-1, we should root out these patients. For the gene defects, including other genes defects, these patients should be ruled out. So finally, we think for the CAEBV and the EBV HLH patients, how to screen the potential effective patients for PD-1 blockade and prevent adverse effects that induce and aggravate HLH. This has been still explored. We hope the more work has been done. And here I will thank our teams for their hard working and for their devotions. I also thanks Kim's invitations and give us 2 good opportunities to discuss and learning. And thanks you all. Thanks.
Thank you so much, Zhao, for that wonderful presentation. And I see that there are multiple questions that have come in that my colleague, Dr. Marsh, will be moderating. I noticed some are in the chat and some are in the Q&A, so we'll have to keep an eye on both. In the future, try to put them in the Q&A if you don't mind. Okay, take it away, Rebecca.
We're not that coordinated.
Yes.
So I'll start with a question from Astrid von Halteren. She says, PD-1 blockade is applied in the context of many types of solid cancers. Assuming that most adults are EBV positive, how often is HLH documented as an SAE? And I'll say that there's a follow-up comment by Gaurav Goyal that some of the newer studies for CAR-T and anti-PD-1 based therapies do capture HLH as SAEs, but a lot of studies don't actually capture it because there's not, a tick box for HLH as part of the CTCAE criteria that we typically use in the United States. So Zhao, do you know particularly about HLH in the solid setting?
So, yeah, I'm not quite understand your question, but I try to answer some of them. And we all know PD-1 have been widely used, just as you said, have been widely used in solid cancer. And for my experience, I also have treated some lymphoma patients, but some of the patients get the HLH after the PD-1 blockade treatment. So we must be careful for that. For HLH patients, we all know the cytokine is very high. And for my treatment, we can see for the CAEBV, after PD-1 antibody treatment, the cytokine increased. They can increase the cytokine, so be careful. We all know for the EBV HLH patients, the cytokine is very high level. If you use the PD-1, perhaps will increase the cytokine. That's be dangerous. Of course, for another side, if we can get rid of the virus or the tumor, perhaps the original disease has been cured, perhaps the cytokine will decrease. So some patients will benefit, some HLH patients will benefit from the PD-1 treatment. But they also have another thing is they will increase the cytokine storm, increase the organs damage. So they have both sides, just like Kim said, have yin and yang, both sides. We must be careful. So we should do away. We hope the PD-1 can get rid of the cancer, get rid of the virus. But we also hope the cytokine storm is not very strong. So this is what we should do. So this is why I do these clinical trials. I want to find the way. Another thing is about the EBV. We all know EBV has very close connection with gene defects. I mean, some of the EBV, for example, CAEBV patients, they have some of the gene defects. So they get HLH, they get CAEBV. For these patients, I don't think they get the benefit from the PD-1 treatment. Perhaps they also have a cytokine storm. So we should get rid of these patients. We must don't treat these patients with PD-1. This is what I think about that. And then this is what I was going on to do.
Yes.
Thanks.
Thank you.
Lots of work to do there. Paul Oversay offers up that be sure to look for atypical presentations like isolated encephalopathy. Our next question, since you mentioned the clinical trials, Zhao, I'm going to do from Randy Crone. And the new blinded trial that's double blind, what are patients getting randomized to? And the ones who aren't going on the treatment arm, and you won't know it'll be blinded, what is everyone being treated with in general?
In fact, it's really difficult for me to go on these two blind clinical trials. In fact, why I do that is because for the first clinical trial, I have shown you the data. I think the data is very good. but I want to confirm that. So I want to do a 2 blind clinical trials. And, I get some of money from the government to go on these clinical trials. These first things, and I also have convinced the company to help me to do that clinical trials. I said, if we can confirm these results by the 2 blind clinical trials, perhaps it's very great things for CAEBV. We all know for CAEBV patients, except the transplantations, almost no effective treatment for these patients. For these patients, we just waiting, then they will die for transplantations. So you will find a new way to treat CAEBV. That's very, very great things.
Yeah.
For me, from my experience, besides transplantations, no treatment has been confirmed can cure the CAEBV. So I think we should try confirm the results. That's
So
why I do the but for these patients, I just tell you, every patient I should tell them this is the clinical trials. If you want to go inside, I will help you. And for the drugs is free, and for the some of the test is free. So I tell them and I encourage them to join our clinical trials. And I also show, and my first clinical trials show some of patients can be cured or can be benefit from the treatment. So that's why some people join us, but it's still very, very difficult.
Yeah.
Very, very
And can I
difficult.
ask, so then the patients who will be randomized to the sintilimab and the lenalidomide, what will the other patients receive?
So that's a problem. Some of the patients, they told me, if I join your clinical trials, perhaps I use some no PD-1, I benefit nothing. If I buy the drugs by myself, I can confirm I can get a good result or not. So that's a problem. That's really a problem. That's why I progress clinical trials progress very slowly. I just ask more patients, more doctors to join us. So this is open label. I hope more people to join, but still very difficult. Is the clinical trials progress very slow. That's true.
And I think we only have time for maybe 1 or 2 more questions. This one's from Vishvdeep Krushu. Would any other PD-1 inhibitor work equally well? Do you have a preference for PD-1 inhibitor?
PD-1 inhibitor. You mean?
Would any of the other ones work as well? I think there's 3 approved in the US. So I think the question is just, do you think any one PD-1 inhibitor works equally well? Or is there a preference in your mind?
I think so. In fact, in our hospital, we have tried at least 2 PD-1 inhibitors to treat the CAEBV. At least some is not in the clinical trials. Just come back. Some of inhibitors also is other countries' products, and it's also still work. So I think for the PD-1, even for PD-L1 inhibitors, also perhaps also can work. So some of doctors also have tried PD-L1. From some of the paper research, they show EBV can induce PD-L1 overexpressions. So I think perhaps PD-L1 is also a potential treatment for CAEBV or EBV HLH. So
There's
I think
your
they
3rd
will
or
work.
4th clinical trial down the road. All right, well, I think it's 11:31. There are some other questions. Now, maybe you can answer some of them in the Q&A in the chat. And Kim, I will turn it back over to you to introduce Nirali.
All righty, thank you so much, Zhao, and thank you so much, Nirali, for joining us for this webinar. So for everyone in the audience, Dr. Shah is head of the hematologic malignancy section in the pediatric oncology branch at the NIH. She serves as an NIH Lasker, clinical research scholar, and in her role as head of the heme malignancy section, Dr. Shah aims to implement early phase immunotherapeutic approaches for high-risk hematologic malignancies. Towards this end, she currently leads several efforts in CAR T-cell therapy for acute leukemia. And today she will be talking with us about her experiences with CD22 CAR T-cells and associated HLH-like toxicities. So take it away, and thank you so much, Dr. Shah.
All right, what are you seeing? Is it the full screen or not?
This is perfect. Yep, we see your full screen. Thank you so much.
Awesome, thank you so much. And thank you so much for the invitation. I'm really honored to be here. So today I'll be talking about CAR HLH. There's no relevant financial disclosures. I'll be talking a little bit about anakinra, but my biggest disclosure for this group is that I don't really know if HLH or macrophage activation syndrome is really the best semantics for what we're seeing, but we are borrowing this because it's the closest thing that we have, and would love to get some feedback from you all, because I think that in the CAR T-cell field, we're really struggling with how to identify this, try to figure out what it is, distinguish it from CRS, if it can be distinguished. And so I'll try to speak to a little bit about those issues. So the objectives are to discuss cytokine release syndrome and the manifestations of HLH-like toxicity, which I will refer to as CAR HLH, in the setting of CAR T-cell therapy, and to outline the need to better understand this manifestation of CAR HLH and the treatment approaches. To make sure that everybody's on the same page, CAR T-cell therapy is a form of adoptive cell therapy, which is a mechanism to overcome the inherent inhibition of the endogenous T cells to target and eliminate cancer cells. In this case, you've got your T cell here with the co-stimulatory domains. You are giving it the antibody recognition properties to have that real, that nice specificity to target an antigen. In this case, we'll assume that that is a CD19. What is nice about CAR T cells is that it is major histocompatibility complex independent, which means that you're not restricted to having a specific HLH for this particular form of adoptive T cell therapy like you would with T cell receptors. You typically have built-in co-stimulatory signaling either with 4-1BB or CD28 with the CD3 zeta. That comprises your basic second generation construct, and what's forthcoming is sort of adding on additional co-stimulatory domains or tweaking what you're going to be doing in terms of the actual construct. But most of what is currently used is either a combination of the 4-1BB with CD3 zeta or CD28 with CD3 zeta, and they give you different properties. But ultimately, you end up having a CAR T-cell construct, which is where you have T-cell functionality coupled to antibody-based antigen recognition. In terms of CD19 CAR T-cell updates, I'm sharing the data that emerged primarily out of the Children's Hospital of Philadelphia, and this is the registrations Aliana study, the phase 2 trial that was testing tisagenlecleucel, which is a CD19 4-1BB CAR T-cell construct. As you can see here, so these, for this particular trial, there is an 81% complete remission rate, which included all the patients for whom a CAR T-cell product was manufactured. These are patients who initially are, chemotherapy refractory, standard therapies have failed, and to be able to achieve a complete remission rate in the 80% is really, really remarkable. And this trial led to the FDA approval for tisagenlecleucel. For the sake of time, I am not going to go into all of the limitations, but I'll say here that a large part of my work in the pediatric oncology branch is to really focus on this issue right here of the event-free survival, because there's about 50% of patients who are going to have a relapse. And so we are focused on developing alternative CAR T-cell constructs, multi-antigen targeting constructs, looking broadly at risk factors that would help to predict who's going to be a long-term survival. And you can certainly see some of, find some of that literature that's now becoming more readily available. But with that background and a prior history of targeting CD22 in the pediatric oncology branch, where in the past we had used an antibody-based target, we developed a CD22 CAR, and I'm jumping directly into the outcomes, which was that CD22 CAR T cells are highly active in patients with relapsed refractory disease. We included patients, even those who had relapsed after prior CD19 CAR, those who had not responded to CD19 CAR, those who had lost CD19 on their leukemia altogether, found a really high complete remission rate in this very refractory population. As I mentioned, was effective in those who had failed alternate strategies, including at this point now the best therapies available. Our cytokine release syndrome toxicity, which is the overwhelming toxicity you see with CAR T cells in general, was overall relatively low. And I'll talk about the grade scale, but basically grade 3 and grade 4, you're talking about typically being in the ICU, having hypotension, needing blood pressure support with vasoactive medications, needing more oxygen requirement for a grade 3, and then for grade 4, you're requiring multiple pressors and needing to have be intubated or have again extensive oxygen support. That rate was relatively low, and when we started this trial, I think this was really remarkable because it was the first time that we were targeting the same leukemia and a different antigen. So to see a discrepant rates of CRS severity, I think was really remarkable because these patients also had high burden disease. So it gave you a sense that there's going to be differences across different CAR T cell targets. Similarly, neurotoxicity was minimal. But the problem we had was that we saw these delayed, extended inflammatory toxicities, which is really what I'm going to be talking about today. And that was occurring at a much higher incidence than what had previously been reported, which was at that point sort of, a case report or occasional patients, or in the context of direct cytokine release syndrome. So cytokine release syndrome overall is a supraphysiologic inflammatory process you see with the onset of CAR T cell expansion, ranges from mild to severe. In severe cases, it can be life-threatening. Neurotoxicity can be particularly worrisome, including events like seizures, cerebral edema, herniation. Over the years, we have gotten much better at all of this. We do preemptive strategies, one of which is now tocilizumab, which is an anti-IL-6 receptor antibody, which is FDA approved for the treatment of cytokine release syndrome. It's a receptor antagonist. And in terms of being able to navigate and try to achieve the maximal potential of CAR T cells, you have to be able to overcome the toxicity signal. And so targeting IL-6 had absolutely demonstrated clinical efficacy in initially the treatment, but now moving towards the prevention of severe cytokine release syndrome. Here is shown sort of a typical patient. I want to orient you to these being the cytokine, the picograms per milliliter, the cytokine values. Blue is IL-6. This black is interferon gamma. This is an alternative cytokine, which I'm not sure why it's listed that way. I apologize for that. And the C-reactive protein. And you can see here sort of the clinical manifestations of what happened in the earliest experience. You have, the IL-6 going up. You have the onset of vasopressors and the onset of fevers. At that point, you give toci. What we're doing now is we're bringing toci a little bit earlier. And so oftentimes we're doing it after, 48 hours of persistent fevers. And what toci is really helping to do is to help offset sort of this entire cascade of this inflammatory signal. And so you can see here, we're trying to block IL-6 from entering the end organs. The important thing, at least from a neurotoxicity perspective, is that we do worry that that may lead to an inadvertent shift of IL-6 potentially going to the CNS because toci does not cross the blood-brain barrier. So we tend to use steroids first for the treatment of specific neurotoxicity syndromes. But you can see here this sort of cascade that happens with the CAR T cell infusion, the CAR T cell expansion. You have cytotoxic CD8 T cells, which are the predominant T cells that have the initial expansion and the killing, and sort of what happens to sort of break that cycle of cytokine proliferation. Shifting over to HLH. So I like this figure because I think that somewhere in here is where we are seeing some of these later delayed effects of CAR T cells, and maybe somewhere in this mimic category. But as you all know more, better than most of us, it is an inflammatory syndrome characterized by a unique clinical presentation triggered by immune dysregulation. And I think this immune dysregulation is what I'd like to focus a little bit more on. In our case, it may be iatrogenic. Obviously, there's primary and familiar cases. People will ask, have you checked for mutations? We did in a few patients, but when we saw that 30 to 40% of our patients were having HLH-like manifestations, we were clearly able to say that this is not an inherited issue in this particular patient cohort. Secondary could be, acquired tick triggered. I think, this disease mimics is what interests me because I think that's probably what we're seeing. And importantly, it's not really a single disease entity. And I think that what we've learned from our experience with CD22 CAR T cells is that as you target different antigens, you have different CAR T cell constructs, you change something about even our manufacturing, which is a separate story altogether. You might see different manifestations in terms of CAR T cells. And I think you have to be really mindful of what you don't know when you go into a new CAR T cell construct. People always ask, what definitions are we using? So I will go to what some of the standard definitions are and then tell you why these don't work. So in terms of thinking about it, right, it's a T cell mediated hyperinflammatory state associated with NK cell dysfunction. We are giving T cells that are triggered by the antigen that lead to a hyperinflammatory state. And I think, at least for those cases where we see HLH, I think that they are not shutting down the way that we would like to. And I will show you some data to say that, that at least if there's a clear hypothesis there that may show that this is really what's happening, at least along with we had not been able to show NK cell dysfunction and have specifically tried to look for that, but there does seem to be a relative NK cell lymphopenia that may be contributing to this. And the manifestations that we see, which I'll show in a couple of slides, include hyperferritinemia, coagulopathy, hypertriglyceridemia, cytopenias, and hepatic transaminitis. Now, this is your standard HLH. And as you'll see here, fever can't really be used because our patients are supposed to have fever. We worry if they don't have a fever. Splenomegaly, when you have a patient with relapsed refractory leukemia, they have big spleens because it's infiltrated with leukemia cells. Our patients have cytopenias at baseline, and it's really hard to know if they get worse or better when you give CAR T cell therapies, and CAR T cells in and of themselves are also associated with prolonged cytopenias in some cases. I will show you some hemophagocytosis because I think this is potentially unique and I think will help to elucidate when you're seeing more of this HLH-like toxicities. Like I've mentioned, we have not seen this, but we've only tested a few patients. Ferritin is problematic because the vast majority of our patients, at least in the relapsed refractory setting, have high ferritins to begin with. We looked at this cutoff and essentially, I want to say 80% of our patients had a high ferritin at baseline. And then this we have looked at as well, but you can see here that you knock out a couple of these diagnostic criteria because you can't use them in a relapsed refractory leukemia setting in a patient who's getting CAR T cells. So again, in terms of this basic pathophysiology, for the sake of time, I'll sort of, skip through this a little bit, but, there is a thought that there is excessive activation of CD8 T cells, and I think I would keep in mind excessive. It may be appropriately triggered. In this case, I'll say it's iatrogenic. We are giving T cells to cause an expansion, but how much expansion is needed? And then what happens when there is this element of immune dysregulation where you can't get the T cells to necessarily turn off the way that you would like? And is there a concern that it's either pathologic? Or let's say in the case of extramedullary disease, do you need to have that ongoing CAR T cell activation to be able to get to every little bit of disease that's there? Interferon gamma is a key mediator of disease development and may be why our approaches to treat cytokine release syndrome with IL-6 doesn't always turn off this later HLH-like manifestation. And as I've shown you, the standard diagnostic criteria is really, really challenging for us to apply in the setting of CAR T cells. So when I present this to a CAR T cell group, the question is, well, it's just severe CRS. And I will say that no, it is not always. What about delayed manifestation? So there seem to be two-time courses. There seems to be a subset of patients where they have cytokine release syndrome and distinguish themselves from, even severe cytokine release syndrome because they go down this inflammatory pathway with a very high ferritin and hypertriglyceridemia and worsening cytopenias. And then this later cohort of patient where for all intents and purposes, cytokine release syndrome is resolved. They are over, the fevers have gotten better. But then you start to see this patient, they could be perfectly fine, they're outpatients, they're doing well, and then their LFTs start to rise, their ferritins start to rise. the CRP is as, completely normal. And you're sitting there saying, why are they so inflamed? What is going on with them? And there's not even an indication to think about how you think about giving toci because it's not indicated. Is it the same across CAR T cell constructs? Absolutely not. Is it really HLH MAS? I don't know, but we are using this because it helps to, as we do new things with CAR T cells, adopting something that closely resembles it is important because you have to treat your patients in real time. And so while we try to figure out the pathophysiology, if you have a patient with HLH MAS and you've given 2 doses of tocine, you've given steroids and they're not doing better, you have to rely on what is established in other disease settings that are close to that, because we have to have our patients overcome this toxicity profile. And then does it matter? Yes, for the reasons that I just articulated. In terms of definitions and limitations, I don't know. There are 2 sets of definitions right now. This is our group here. And, we basically decided to do major and minor criteria, and you have to have CRS. We did not have a single patient develop HLH if they did not have CRS. You have to have an elevated ferritin. And you'll note that I have this ridiculously high cutoff of 100,000. And that is because our patients had really, really high ferritins. And I will say that that is specific to CAR T cells, but that probably you're looking at a log lower for CD19, which goes back to this other group here, which is a Nirali group et al. From MD Anderson, and they have a ferritin cutoff of 10,000. If I use 10,000 on my trial, everybody would have met the major criteria, and that is not what happened. For our minor criteria, we were like, well, you have to have hepatic transaminase elevations. You need to have 2 of them, renal insufficiency, coagulopathy, evidence of hemophagocytosis on a bone marrow. And then we do look at hypertriglyceridemias and cytopenias, but there is currently not an immunotherapy specific HLH set of guidelines that we are currently using because we are trying to understand this. In terms of HLH-like manifestations as a CAR T cell variant, I started to allude to this a little bit. So we see all of these cytopenias, hepatic dysfunction, and so I want to take you here. So this is a typical cytokine release syndrome patient. This is interferon gamma on the left y-axis, and then MIP-1 alpha, IL-10, and IL-6 on the right. This is from days after CAR T cell infusion. So patient is perfectly fine. They have a fever, inflammatory markers go up, inflammatory markers go down, they're clinically improved, and we all are perfectly fine. What we started to see in about, like I said, 30 to 40% is that they would do that. They would have cytokine release syndrome. You see things go up. The blue here is the IL-10 and black here is IL-6. IL-6 never comes back again. And then you have this entire inflammatory cascade that follows, it peaks about 7 days later. And you see interferon gamma is at a new peak. MIP-1 alpha is a new peak and it sort of stays persistent. This is a patient who had sort of a cascading course. And again, you see this, what's driving, so IL-6 is down here. And you can, this little blip, I'm not exactly sure what it is, but it's really this interferon gamma and this MIP-1 alpha. And as I said, people talk about giving toci, but if you have a patient who's afebrile and otherwise doing well, you don't have an indication to give it the way we would think about giving tocilizumab. And then this is our clinical patients. So just to go through the evaluable patients, we had 52 patients who had CRS, and 21 of them had met our definitions for CAR HLH. Amongst those who did not have CRS, they didn't have HLH. So you need to have, again, at least some T cell activation. In terms of clinical manifestations, the red is those with HLH, the blue is those without HLH. And what I want to show you is that there is no difference in C-reactive protein. Temperature, maybe, but again, temperature was not a primary manifestation. But then you look at the ferritins, the ALT, the AST, the bilirubin, at least for some time, triglycerides. And this, I want to always say that we don't always check them when they're fasting. So I think that it's a little bit skewed, LDH. But you start to get a sense that these are a little bit different. And then the other thing is we have, for our most recent paper, what we did is that we've presented data in 2 ways because there's, outcomes after CAR T cell infusion, but that may not necessarily be the best biologic time point because patients can develop cytokine release syndrome at any time. Our median time for CRS onset was day 7, but it ranged. We had one patient develop CRS at day 21. And so we have normalized all of our data to CRS onset as a time point that we believe is more biologically relevant. and gate all of our clinical outcomes as well as our cytokine profiling, as you'll see here, based on that. Our supplemental slide also has all the data based on CAR infusion. But again, here, there are select differences in cytokines, and I'll finish up in just a few minutes. Interferon gamma, again, IL-1 beta is going to be important because I think that this is something that we can target, and there's good efficacy data for anakinra utilization overall, MIP-1 alpha, and then a few other ones where you do or do not see differences. And then, our group is not the first one to describe that there were differences in cytokine profiling, but I think this is where the field is really at a loss because with the initial experience of CD19 CAR T cells, it seemed to be the symptoms were on top of one another. There was a cohort of patients with severe CRS who also had these elevated markers. And this is work from Dave Ticci's group and published in Cancer Discovery 2016 from CHOP, where again, they saw the significant overlap between CRS grades 4 and 5, that were coincided with this HLH, but as I'm saying, we're seeing delayed manifestations. And then lastly, what we saw as we sort of dug deeper into this is sort of try to understand this, who are the patients who are getting HLH and what are we seeing? So again, keeping the same color scheme, the red is the HLH, blue is without HLH. And again, this is only including patients who have CRS. So patients without CRS are not included and do not confound this data set. So this is looking at bone marrow percent CAR T cells. You can tell here, this is the median. It's much higher in the bone marrow at the restaging time point. We did not see a difference across disease burden. This is looking at the bone marrow NK cell. So there's a relative NK cell lymphopenia. And then this is a bone marrow T cell to NK cell ratios overall. And you can see here a similar pattern here where, again, you have, not only do you have a higher expansion, but you can see that they're persisting a little bit longer. And I think that that probably is suggestive of why we're seeing some of those later effects. And then again, this relative NK cell lymphopenia. So why does it matter? Again, I think that patients can get into big trouble with these HLH-like manifestations. They become cytopenic, you give more steroids, they become more immunocompromised, they have DIC, multi-organ failure, and they may not improve despite optimal CRS management. The management of CAR HLH is really variable. I think, there are folks who talk about using etoposide. We have never used etoposide. And we don't use the standard CAR HLH with the dexamethasone. We've been able to use actually much lower doses of steroids to be able to navigate this, and our approach is moving towards preemptive. But thinking about beyond tocilizumab, and I'll talk just in the next slide about anakinra, but there's ruxolitinib, some thoughts about emapalumab. There's a recent paper that talked about this as well. And again, you're trying to balance, you want your CAR T cells to work, you want them to retain efficacy because you're trying to get rid of their leukemia, but you need them to tolerate their toxicity. So because of the prevalence, we needed to treat patients. We did not, I tell people, I present this beautiful story of where I had, cytokine data in real time. I did not have any cytokine data in real time, but I had patients who needed to be treated. So this is a patient who had exactly this pattern. This is hepatic transaminases, cytokine release syndrome, everything, this is the ferritin who's actually peaks earlier, comes down and then goes back up again. And then you see here the ALTs were in like the 1700 range. No idea what was going on. This is really, really early. And the hematopathologist calls me at 10 p.m. and it's like, there's active hemophagocytosis. And so we're like, okay, maybe there's something. The patient was clinically well. So we used anakinra and there was full resolution of all of this within a month. And the patient was able to attain an ongoing remission. And so we've incorporated this into our preemptive strategies. Rebecca mentioned this earlier, there is not an HLH grading criteria. So I've made one up. It is not endorsed, it is our own, but we're like, we need to do something. So we're using this for our trial to see if we can at least try to understand and come up with some type of grading scale. And to end, so recognition is needed to optimize patient outcomes. I think developing a clear nomenclature to describe and capture this toxicity is needed. I've been using CAR HLH because I think it links it to CAR T cells. I do think that probably some will not like the HLH part of it, but it's the best that I have. Grading schema is needed, severity, timing. How do we prevent this toxicity? Just like we're moving into preemptive prevention of cytokine release syndrome. And I think we need consensus management guidelines. We probably need consensus recognition guidelines first, but when is treatment indicated? What is the first line approach? Can we go away from things that say we're going to give etoposide when there is really not much data to use it? And I think we could do better. And I will end there. Many, many people to thank, but sorry, I know I went a little bit over.
That was fantastic, Nirali. That was amazing. Thank you so much for giving this. We do only have 4 questions, so I'm going to jump right to it. So Randy Crone asked about anakinra, but you sort of touched on that. So I'm going to skip to his next question. How about hypomorphic or partial or complete dominant negative mutations in the familial HLH or other HLH associated disorders in the patients with CRS or HLH?
Is a question about whether we've looked for it?
Yes, and do you find them? Like, do you, for instance, find a het PRF1 pathogenic variant? Do you find a het STXBP2 mutation, et cetera?
Yeah, so I would say that this is something that is just greatly lacking. We have only done HLH testing, like genetic profiling, on probably 3 patients and didn't have anything. And like I said, it's hard for me to say that this percentage of patients is having HLH to like toxicities. And then, you know, we have a 30 to 40%. What I glossed over is what is the incidence of CD19 CAR T cells. And that's a little bit unknown, but it's probably in the order of about 10 to 15%. It's hard to say that all of these patients would have some type of common genetic predisposition, which is why I think it really is a T cell activation issue, and then maybe that prolonged persistence. But I do think as a community, we need to think about this a little bit more, but it's just hard to say that that would be the key finding.
Yeah. And there's a great comment by Daniel Elfasi in the Q&A. I do not have time to go through it, but I would encourage all of you that are on the webinar to just take a look at that. Good ideas for potentials for nomenclature down the road. Julie Tolano asks, what % of patients who develop HLH post-CAR T cell therapy have an identified infection concurrently? And then someone else later on asked about any EBV viremia in your cohorts.
Yeah, so we've looked at we've looked at CMV and EBV. That has not been an issue and does not correlate with our findings. In terms of infections, you know, our patients will have infections, but more often than not, it happens after HLH onset, after you've started like the deep steroids and everything else like that. And I think that we've gotten better with time, but I think one of our problems early on was that we were not recognizing it for what it was. And so they got infections because their underlying inflammatory response wasn't adequately treated. But I would say, again, I don't think infection is a clear trigger, but I think untreated inflammatory responses and immunosuppression are absolutely predisposing this patient population. So we really need to try to prevent this from becoming severe.
Scott Canna asks, if tumor is low or lower during the late stage CAR HLH, is it tumor antigen or something else sustaining T cell activation? He wants to know, does CAR HLH correlate with lack of CAR T contraction? And you did sort of touch on that, but if you could sort of answer that question again.
Yeah, so it's a complicated one. I do think that in patients with ALL with extramedullary disease, I think to some extent those patients tend to have less contraction and more prolonged persistence because there is some degree of antigen there. But if I look at patients where they don't have those extramedullary manifestations, where it's difficult to really assess what their disease burden is, for patients who have achieved remission, we don't see any differences in terms of remission status, that most of the patients would have had HLH and would have no evidence of there being ongoing antigen. And so I think that there is something about particular patients and what is triggering their T cells to be particularly more persistent when it's not antigen dependent. The other thing that I think is tricky is trying to figure this out across multiple CAR T cell constructs. For our CD22, if anything, our CAR HLH patients had a slightly higher rate of complete remissions. It's not statistically significant, but absolutely, it was not a detrimental effect. That has not been the case. And I think the group at St. Jude actually, and I think there's another group at MD Anderson actually talked about HLH. And I think the problem is that some of those patients end up having this activation and don't eradicate their disease. So then you have the trifecta of, having to deal with an inflammatory response and ongoing disease and having to try to manage all of that all together. And so I think trying to tease that out is really challenging.
Yeah, absolutely. And we are over. I'm going to ask one more question and then we're going to end to be respectful of everyone's time. Vishvit Kushu says, can you re-look at things in your secondary HLH patients with relation to obesity? Because dysmetabolic hyperferritinemia may also contribute.
Absolutely, we could do that. Obviously I wouldn't have the data, but we are actually looking at our outcomes in patients with obesity and have a little bit of a signal there. And then I just see one comment from Michael Jordan about CAR T-cell designs as a risk factor for CAR HLH. I will say that the 4-1BB constructs, as we know them right now, the more persistent CARs seem to be more associated with HLH-like toxicities. And I think that makes sense because the contraction from the CD28 co-stimulatory domain seems to be less. But I will say that that is not an absolute by any means. And there are reports of patients receiving Yescarta, which is a CD19 28 zeta co-stimulatory domain, who have had delayed manifestations of CAR HLH as well. But I do think if you were to say which one has a higher predisposition, it would be a 4-1BB currently.
All right. Well, Kim, I will take it back to you to close us out.
All right. Well, thank you. Thank you so much, Nirali and Zhao, for those two excellent presentations. Thank you for everyone in the audience who's attended. I would like to remind everyone that on April 7th will be the next Histiocyte Society webinar. It'll be hosted by the Rare Disease Committee. You can please see here ways that you can support the society by becoming a member and also signing up for Amazon Smile. And Kathy, thank you. Everybody, if you have a moment when you sign out, please fill out the survey. It helps us to plan future webinars. So with that, I thank everyone for attending. It was a wonderful morning. Have a good day, everybody.
Thank you, everyone.